Hello. Today we're going to be talking about healthcare inequality as it relates to race, class, and culture. When we're thinking about the kinds of people who encounter the medical system, we have to be aware that there's diversity and that there really are many different kinds of diversity. We often think just in terms of race. But when encountering patients, it's important to remember there are other kinds: gender, ethnicity, culture, age, nation of origin, language, religion, education, socioeconomic status, living conditions, even familiarity with the healthcare system. When we treat all patients as if they're the same, which often ends up meaning like a white middle class male, this can lead to real problems. So we should think about different types of cultural differences. A major type of difference has to do with just conceptions of health and medicine. To give a little example, think when somebody sneezes, what do? You say, "God bless you." And why is that? Well, people used to believe that when you sneezed, your soul could escape through your nose. So it was therefore important to bless the person immediately, lest any nearby demons take over the vulnerable body. But for most of us, saying bless you is now just a cultural ritual, a nicety, a show of politeness. But we don't actually believe that demons may take over our bodies, or that illness in and of itself might be a sign of a problem with the soul or spirit. And this is because most Western societies are dominated by the biomedical model of health. And what do we mean by this? Well, for us, we tend to believe that illness and treatment should come from the Western scientific tradition, including ideas about germs, biochemistry, biophysics, etc. We tend to discount the role of the soul or faith or sort of ephemeral things. We're very grounded in this biomedical model. And certainly you see this in the readings you've been doing in The Spirit Catches You. But of course, this is only one tradition of many. Throughout the world and in different communities within the US, there are other belief systems as well. These ethno-medical belief systems are culturally unique beliefs and knowledge about health and disease. If you believe, or rather, if you assume that everyone is operating under the Western biomedical model, you may have trouble treating them and getting them to that dreadful word from the book, comply with medical treatments. So what might be elements of an ethno-medical model that you're missing? One thing would be about attributions of illness and health, because many cultures attribute illness to spiritual forces, as you have seen in The Spirit Catches You and You Fall Down. Think about the different kinds of beliefs that the Hmong have about what causes illnesses, what removes illnesses, and a conception of the way people interact with the world, the way health is related to behavior, beliefs, etc. Another thing to think about would be the way cultures approach people's ideas about death and dying. Some cultures might take a fatalistic approach to disease, believing that God has ordained their illness. And if they believe this, they're therefore less likely to adhere to biomedical treatments. Similarly, if they believe they're simply going to be rewarded for being a good person and that health will naturally ensue, they may be less likely to seek out treatment. They may also just assume that the way of the world is, birth and life and death in a comfort with death and dying that certainly in the US we don't have. Now, another thing to consider is, of course, religion. A patient's psychological state can significantly affect treatment. So ignoring belief systems that we find in religion can result in poor outcomes for patients. We often see medicine as outside the realm of medical practice and care, but patients' religions can play an important role in their outcomes. Religions offer strong support networks for people who are ill, and strong support networks have been linked to positive physical and psychological outcomes. For instance, studies show that regular churchgoers are generally healthier, having a lesser risk of hospitalization, depression, and reduced mortality rates. Knowing a patient's religious beliefs can help a doctor provide better care. In addition, there may be cultural taboos against certain Western medical techniques, so surgery, blood transfusions, transplants, lumbar punctures. Those are commonplace. A failure to recognize those aversions may have poor consequences for the patient and the provider-patient relationship as well. Even if patients are going along with Western medical practices, they may also simultaneously be seeking out traditional folk remedies from their own cultures, from exorcisms to herbal remedies to bloodlettings. And if a physician doesn't know about those other treatments, there may be complications for the patient in terms of treatment in the Western tradition. Another thing that we should be thinking about in terms of cultural differences has to do with immigrant communities and the process of acculturation. Immigrant communities in particular may face greater risks, health risks, when coming to the US. Because when they come here, they're faced with a different lifestyle, one that's usually more sedentary than the ones they left, and eating habits that are also less healthy. American food is served in larger portions, it's high in sugar and fat and processed food. So if these are outside of what you regularly eat in your community, these may cause real problems for you. This leaves these communities prone to health risks like heart disease and diabetes. But because they don't necessarily approach health in the same way as the Western model, they may not connect the changes in lifestyle with the health outcomes, and thus they could be doing very little to change these habits. Additionally, immigrant communities are facing many stressors from dislocation that can lead to anxiety, stress, and depression. These conditions in turn can lead to substance abuse as well. And of course, we can't rule out at the moment the way the political climate affects immigrant communities, the stress of living under threat and hostility from political and governmental forces. If providers are unfamiliar with these stressors, or the communities are unaware that the treatments are available, these people can go underserved by the medical community. And this leaves aside all of the issues we've talked about in the past in terms of access to care itself. Another cultural difference we should be thinking about has to do with informed consent. Because in addition to these basic conceptions about health, different communities approach communication about health in different ways. In the West, we have a very legalistic tradition that's evolved, stressing the patient's right to know. Decisions are considered individual in nature, and privacy laws often keep the provider from discussing the health of an issue with others. But in more collective societies, this focus on the individual is problematic. Additionally, in patriarchal societies, the health decisions may not really be in the hands of the young or the female. So Western discomfort with these traditions doesn't actually change the importance of them to the patient and to the patient's community. So particularly if you find yourself of a liberal bent and believe that this is up to an individual, a woman, for instance, has the right to make her own decisions around healthcare, you run the risk of actually not paying attention to the concerns of that individual patient who simply subscribes to a different belief system. The last thing to think about in this section is direct and indirect communication, because there are real differences in how people prefer to talk about health. Western approaches are often based on this direct communication from doctors about illnesses. We tend to prefer if physicians don't beat around the bush, for instance, whereas other cultures prefer ambiguous or indirect communication about health. So this is something really to consider as we're talking to patients. What is it that they like? And it's worth noting here that this isn't something that just has to do with different cultures. Different people may have different ideas about what they prefer. So you can have two people from the same culture, one who prefers a very direct style of communication and one who prefers an indirect model. It's also useful to think about this, when delivering in diagnoses. What way can people best hear what you're saying, particularly in the case of terminal diagnoses, when we should be thinking about all of those other aspects of culture that we've mentioned so far? This is also something we should be thinking about in terms of translators. When you're using a translator to communicate with patients, problems can arise. If cultures have different conceptions of illness, the causes, direct translation may actually be difficult. And since translators are supposed to translate without omitting or changing anything, communicating in a culturally sensitive way may be difficult, even if the translator knows the culturally correct way of phrasing things. We'll pick this up in the next video.